Hello again, and welcome to this edition of Doc Talk with Monument Health. My name is Mark Houston, and joining me today is Dr. Pial Hope, who is a general surgeon specializing in metabolic and bariatric surgery.
That's
correct?
Right.
Well, welcome to the show, Doctor. Good to have you on.
Hey, thanks for having me.
Yeah,
really appreciate it.
I'm so happy you came up to talk about this because it's robotics, and I have been so excited over the past few episodes that we have been discussing this technology that's come into Rapid City. That I think people are very interested in, might be a little apprehensive about as well. So I'm glad you're here to kind of explain this a little bit. What brought you here, though, Doctor? I was looking at your bio online, Michigan, Texas. You just told me you're born and raised in Los Angeles.
That's right. Yeah.
So how did that journey lead you out here?
Sure. Yeah. It's actually a really interesting story. When I was in general surgical residency training in Southeast Michigan in the Detroit metropolitan area, one of my co-residents, Dr. Brianna Connett, she actually was recruited to Monument Health. Her mom's side of the family is from South Dakota or actually Deadwood area. And she was looking at a job out here. So she signed as a fourth-year resident, and I was 1 year ahead of her. So as a fifth year, she couldn't stop talking about the place. She really, really sold it to me. And her passion and her love for the job, it seemed, was infectious. So I said, okay, I'll check it out. And I came here, interviewed, and I also fell in love with Monument Health and the city of Rapid City. And the rest kind of is history. And I came here really because Brianna, or Dr. Connett, essentially said, this is a great place, you have to check it out.
Did she talk to you about the winters, though?
She did, yeah. I mean, I did my medical school in Erie, Pennsylvania, where it's one of the snowiest cities in America. I did, residency in Michigan.
In Michigan, so you've had the tastes of it.
Sure,
I mean, Los Angeles, Texas, obviously, that's a shock, coming out here for sure.
Yeah, the transition from LA to Erie, Pennsylvania, that was...
Big one.
That was a big one.
Well, that's all the way across the country, too.
Right.
I mean, the shock of all of it, really.
Yeah.
So what led you into metabolic and bariatrics and what you do now then?
Sure. Yeah, absolutely. I always knew I wanted to be a surgeon when I was in medical school. And so I pursued general surgery for that reason. Where weight care and obesity medicine and metabolic and bariatric surgery kind of really became a passion of mine was on the bariatric surgery service as a resident, as well as a medical student doing surgical rotations, seeing how single interventions such as weight loss surgery can affect so many facets of someone's health and really alleviate, mitigate, or even resolve many of their weight-related problems. And I thought that was that was miraculous almost in a lot of ways. You had patients with so many issues that were lifestyle limiting, and the quality of life was a lot less than it could have been. Then you intervene, or you do this procedure, or you put someone on medications, and to see how things turn around and to see how well they do thereafter, it was really inspiring to me.
So it was satisfaction for you then. I mean, there was just a good feeling when it's all done to see that outcome.
Yeah, absolutely. I mean, patients coming in wheelchair bound, not being able to really participate in many of the activities of daily living a year after, say, a weight loss surgery, walking into the clinic. So, right. I mean, that's kind of, it's not just improving life expectancy, but also the quality of life that one can have.
Well, and I think, too, a lot of people get the perception for people that have the issues that you deal with all the time is like, well, why don't they just eat less, or why don't they just exercise more? Because that's something that well, sure, of course, we all understand that.
Sure.
But there's also mitigating circumstances as well that I think you see that like I said, it kind of leads to that satisfaction thing when you can help these people out.
Certainly. And I think you really hit the nail on the head there. And that is to say, for as long as I can, recall, even for me personally, it was always those two main things was, eat less, move more. And that's absolutely true. You can't deny that there's important environmental things you can do
right.
That would help with weight care. But it is a little tone deaf sometimes to say that to patients that come in time and time again seeking help. And sometimes getting to the point where they're frustrated or feeling like they're let down by the healthcare community, because it's not really the nuanced view that we should have as healthcare providers about obesity, which is a chronic, complex disease process, only a little bit of which now we're understanding better and better. But and I think, it's now finally, with the advent of some of the newer medications, as well as some of the technologies we have available to us, for example, the robotics platform, the Vinci surgical platform, that awareness is being built, and people are seeking out and getting the help that they need.
Right.
So, absolutely, and it's a real passion of mine, is access to care and raising awareness and destigmatizing obesity, which is just like any other chronic disease, can be controlled or even cured with the right kinds of tools.
Okay. Well, you brought up the Da Vinci Xi. I realized it was not 11 when I was researching this too.
Right. Yeah.
So I love to get on and watch videos of, again, not the procedure itself, because I can't handle that.
Sure.
But I do like the animated. They have a lot of great videos you can watch on this. My first initial surprise when I saw the machine was its size.
Sure.
It kind of struck me as much larger than I would expect. And we'll get into that a little bit here as we talk about this some. When you started in the process of becoming a surgeon in this area, what technologies were available to you when you started?
Sure. Yeah. The Da Vinci robot actually
it's
has
been
around for more than 20 years.
Oh, really?
Yeah. So, the robotics isn't necessarily a new thing.
Right.
However, the technology's really progressed quite a bit since its nascency, or the early protocol period, the prototypical periods. So yes, when I started my general surgical residency training, we had the Da Vinci robotic system. Not every residency necessarily at that time had it,
Sure.
but we were lucky enough that we had at least, I think we had 2 at the main hospital, and we had 1 at the smaller community hospital. So
it's evolved. I mean, it's even in that 20-year period, it's changed quite a bit.
It's changed quite a bit. The Xi has been a game changer, even though it's almost 10 years old now.
Yeah.
Yeah, we had that, but we did definitely do more straight stick laparoscopic surgery. When I say straight stick, I mean just how using instruments that you're controlling directly by using your hands,
right?
Versus the robotic platform or Da Vinci Xi system, where you're in a console, you're still 100% in control of the operation. No part of it is automated, but you're not necessarily physically in proximity to the patient as much. You're more at the console, which is in the same room.
And I think that's a question that a lot of people have when they hear robotics in medicine and surgery, is like, well, where's the doctor? And so far, every doctor we've talked to about this has said, well, I'm right there. Right. I'm the one that's running the equipment, right?
Certainly, yeah. It facilitates the operation. It doesn't do the operation. The surgeon is still performing every aspect of the operation, starting with initially docking the robot, putting the ports in to be able to even connect the robotic system to the patient, and then breaking scrub and doing the operation. So
what kind of training then do you go through as a doctor, since you've had it in your practice the entire time you've been a part of it?
Sure.
I'm assuming you've either assisted or actually done surgeries the old way, I put in quotes, like you've said.
Yeah.
So as you train on that, how does that work for you?
Certainly, yes. So many people have been surgeons out in communities and various centers well before the robotic system really took off as a viable option for patients, as a modality for surgery. And there's multiple ways in which to become adept at using the system. One is you train on it as a resident, and of course, most residencies nowadays will have robotics experience.
Yeah.
If not all. I'd be surprised if there are a few that didn't have any robotic experience. Beyond that, you have fellowships, which are after completing your surgical residency. There are fellowships that basically focus on minimally invasive surgery. So it's things that you traditionally would do either laparoscopically, straight stick laparoscopically, or open but focusing on using the robotic platform or other minimally invasive techniques. So that's fellowship training for you. Beyond that, there are courses and labs that are sponsored by industry, specifically for the Da Vinci Xi by Intuitive Surgical, where you go, you get lectured, or you have lectures by kind of master surgeons who are known to be very adept at the robot, and they teach you how to essentially the fundamentals of the robotic system. And there are progressive or higher level courses that you can take to master using that platform. The most important thing to understand is that while the modality has changed, so you could laparoscopic surgery, for example, robotic surgery, or open surgery, all of which are integral tools in a surgeon's toolkit. The principles of surgery stay the same. So as long as you're a good surgeon or you understand the principles of surgery, the tools that you use could change, and you can very easily adapt new technologies. So that's the most important thing, is a good foundational understanding of surgical principles.
So really quick, explain, because I want to talk about the advantages of the robot.
Sure.
But explain just what a bariatric surgery is.
Sure, yeah. It's important to, sometimes we'll say bariatric surgery, sometimes we say weight loss surgery.
Sure.
At its core, it's, metabolic and bariatric surgery. It's metabolic surgery. What does that mean? Well, it's kind of like, think of it as diabetes surgery or high blood pressure surgery or, high cholesterol surgery. Things you would do to improve your medical problems that are due to certain underlying metabolism issues or derangements. So what is a bariatric surgery or a weight loss surgery? There's different kinds you could do. And, the primary goal or objective is weight reduction. However, that doesn't have to be a patient's primary goal or your primary goal. Your goal could be that I want less pain when I move, or I would like to get off my insulin, and I feel like my diabetes is just getting more and more difficult to control. Or I hate the CPAP machine I have to wear all the time, and I wish there were a way for my sleep apnea to be cured. So goals could be different, and it's very individualized what your values are and what you would like to achieve. But all of those things happen due to a reduction in weight. And so what is a bariatric surgery, or what does a bariatric surgeon do? Well, many things, but at its core, it's doing operations to reduce your weight, which has so many or innumerable downstream effects that are positive for patients, including, decreasing mechanical shear stresses across joints, so maybe less pain with movements, and improving your metabolic profile, such as your sugar, your diabetes, if you have that, or cholesterol problems, triglyceride problems, etc. So
then how once they've let's talk about this before we get into the robot a little bit more. Who is a good candidate for this type of surgery then?
Sure. Yeah, that's a great question. Thank you. So there are certain criteria that insurance companies, of course, have, and those criteria were actually modified a bit, at least as far as our society is concerned, the American Society of Metabolic and Bariatric Surgeons. I'll just kind of briefly go over the generic category. So you have to have the disease of obesity. So that means a quick and dirty way, basically, that has been used mainly because of insurance companies, as the BMI, which is body mass index. It's just a calculation you get from someone's height and weight, and it tells you, based on the number, various categories of obesity. So there's class 1, class 2, and class 3. So if you have a BMI that's between 35 and 40, you'd be a good candidate for a bariatric surgery. Insurance companies require you to have one weight-related medical problem in order to qualify. So you may have insurance that has benefits for bariatric procedures, but you may not qualify to use those benefits if you don't have a weight-related problem in addition to a BMI of 35 or higher. And I have my opinions about that. I think it's very restrictive because I think many people could benefit from a bariatric procedure or weight loss surgery. that may or may not have a comorbidity or a medical problem related to their weight. And that's specific too. There's some that they expect to see. And even though you might have a medical problem that's certainly due to weight, it might not be the one that qualifies
Right.
for that company. So that's one way to qualify. The other way is if your BMI is 40 or greater, so it's considered class 3 obesity or greater, and you have benefits through insurance, then you would qualify for bariatric surgery. And it doesn't matter whether you have a weight-related problem or not. At that point, most people, the vast majority of people, will have a weight-related medical problem. But so it's a BMI of 40 or higher, or a BMI of 35 and between 35 and 40, with a medical problem that's due to your weight.
Okay. So somebody has qualified, all right? And they've come to you and you said, yes, we can do this procedure for sure. So they get wheeled into the room, and this is when I want to go to the size of this robot.
Sure.
Just coming from a background of growing up as a child, watching science fiction and hoping that one day these things are going to exist.
Sure.
And now we kind of live in that age when they do. I get super excited to see how this equipment works. The patient lays down, and you're getting them prepped and ready to go. And then when does the robot come in, doctor?
Sure, absolutely. So, after going through the usual procedures, such as doing a surgical timeout and having already have the abdomen prepped and draped in the case of abdominal surgery, we have to gain access into the belly. So there has to be a way to first get into the abdominal cavity. So that's done by the surgeon. There's various methods to do that. Once you're in there, to do laparoscopic surgery or minimally invasive surgery, you have to blow the abdominal cavity up with carbon dioxide gas. And that's just to create a nice working space so you can manipulate the instruments inside the abdomen. Otherwise, the abdominal wall is collapsed against the organs and there's not really any space to work. So first step is to just gain access to the abdomen, and we say insufflate or blow up with carbon dioxide gas to create a working space. Next, you put in the various trocars, and it depends on the procedure you're doing. It could be anywhere between 4 to 5 to 6 trocars that you need.
Now, what are those?
Those are just these, essentially, they are these ports or
hollow. Yep.
They're like these long tubular things that essentially are different sized, and you would have them go through the abdominal wall, and they serve as an anchor for your instruments to be able to go in and out of the abdominal wall. They're like little tunnels, essentially.
Okay.
So you put in your ports, and then once the ports are in the abdomen, use a camera the whole time to watch things go in and out. And you dock the robot, meaning you attach the robot.
So this is
arms.
when the robot comes in at this point.
That's right.
Okay.
That's when the robot comes in, and you use the robotic arms to attach to these trocars or these ports you placed. Once everything's attached, you can target the system. You find the location where you want to work. You point the camera there, and you have to basically calibrate or target the system to essentially move in a way and optimize the positioning and placement to work in that space. So after that, your robot's docked, your instruments are put into the patient through the system, and the surgeon then breaks scrub, sits at the console, and starts doing the operation using the robot.
I watched in the video of where the doctor's fingers using that robot too, and how it's like, I don't really know how to describe. How would you best describe where your hands go on that thing?
Sure, it's there's these small there's these Velcro straps for your fingers. You put in your fingers, and it allows for various degrees of motion. And what you can do is when you twist your hand or rotate your hand, so too will a robotic arm inside the patient's abdomen rotate in a similar way. It doesn't have exactly the same degrees of freedom as a human hand would, but it's quite good.
Right.
And you can also readjust and re-rotate versus once you reach the extent of your rotation on your hand, that's it. You can't rotate anymore. But then you can basically clutch and go back and rotate even further that way. So you can do 360. You can move left and right, up and down. It's phenomenal how much it facilitates an operation that's laparoscopic, whereas the degrees of freedom are sometimes limited when you do the traditional straight stake laparoscopic surgery. That isn't to say there's any worse outcomes with
Right.
straight stick
Oh, of
laparoscopic
course.
surgery. Outcomes essentially it hasn't been demonstrated that they're necessarily better or worse. It's just a different way to do the operation that greatly facilitates ergonomics for the surgeon, as well as there's some discussion about pain being less or discomfort being less after performing the operation from using a robotic system.
Well, from what I understand too, it's very minimally invasive as well. It seems like 4 or 5 different parts, very small. Is that accurate?
Yeah, that's right. That's exactly right. So the incisions that one would have on their body would be usually ranging from half a centimeter up to maybe a centimeter and maybe 1.2 centimeters. Oftentimes we're having to make the incision bigger, not because we need it for the operation per se, but rather to take something out of the abdomen when you're doing surgery. So in the case of one of the bariatric operations where you do a sleeve or a sleeve gastrectomy surgery for the sake of weight loss, you have to remove 80% of someone's stomach and take it out of the abdomen through one of the incisions. Oftentimes, in fact, every time, the incision is too small in order to do that. So we actually have to increase the size of the incision just to take the stomach out. So in as much as the tool, it's amazing how little space or how small incisions can be. And the only time they're bigger is when we have to extract the specimen.
So what to you is the greatest advantage of using this robot?
That's a tough question. There's so many.
That's good to know, though. I mean,
right.
that there's so many.
Yeah. I think definitely visualization. The high definition camera offers some really next generation visualization that you really couldn't get before this technology. Additionally, when you're doing laparoscopic surgery, you need an assistant or someone to hold the camera, just dedicated to holding the camera. And that works fine for the most part, but that's an additional person to hold a camera in a space that's already crowded with 2 to 3 other people. Additionally, as a surgeon, it's nice to have total control of the operation. I can turn the camera on the robotic system on my own by toggling to the camera and focusing on what I need to see without having to verbalize it or without having someone else having to anticipate my next move. So visualization probably is one of the best advantages of using the robotic system.
Okay.
If I had to pick a few others, I would say ergonomics for the surgeon as well.
Yeah, like you mentioned, the ability to turn.
The ability to turn, that might be a surgeon-specific benefit, but at the end of the day, if your surgeon's doing multiple surgeries that day, it's important that they're somewhat comfortable.
Oh yeah,
and
of course.
They're not feeling so fatigued
right.
at the end of the day
yeah.
that there's a compromise of the procedure later.
Sure.
It doesn't happen, but it increases longevity in the operating room, and it's important where there's just not enough surgeons or doctors to do things that we can extend the life of a surgeon providing a service like that would be a good thing, I think.
How many of these do you perform, like in a day, in a week, in a month?
Sure. You're talking about robotic surgeries?
Right.
I've tried to go to a 100% robotic model.
Okay.
So most of my cases at this point are robotic that I am boarding. So it depends on the surgeon and their volume. Everyone's a little different, but you can probably do 3 to 4 pretty major robotic operations per day. That you're in the operating room.
Really?
Yeah. And just depending on other things and efficiencies, you could possibly do more.
Yeah.
So there is some, when we went from an era of primarily open surgery, which is how surgery had always been done traditionally. When I say open, I mean just incisions that are large to do surgery. And there's nothing wrong with that. And that's important that surgeons know how to do open surgery because the bailout from a minimally invasive approach would be an open operation.
Right.
There was some backlash when laparoscopy made it onto the scene or tried to become more mainstream. people would say, no, I could do it much faster open. I don't know why you need all this technology. It's just makes everything take longer and it's not as safe. And so there's usually, when there's disruptive technologies, traditionally there's always backlash until finally everyone starts adopting it and realizing its merits. So we went through a little bit of that between with the introduction of the robot and the people who were diehard laparoscopists and really believed in laparoscopic surgery. The most important thing to remember is it's essentially the same exact thing as laparoscopic surgery. You're still using tiny incisions, instruments, and cameras. The only difference being that now it's being controlled through a console by the surgeon instead of directly by the surgeon at the bedside.
Right.
That's the primary difference. So, you could additionally, as technology improves and as the system improves, efficiencies will improve.
Yeah.
And costs will go down when you have more competition and more
Right.
products coming out that essentially lead to prices going down. So, if you compare the very beginnings of robotic surgery to the most refined and complete, or the very end of laparoscopic surgery, I wouldn't say end. It's
Right.
kind of all a continuum, but you can't compare the highlight reel of laparoscopic surgery to like the nascency or the beginning of robotic surgery. It's not going to pan out in favor of robotic surgery. But now, with more than 10 years of the XI system being out, more and more studies are coming out how efficient it can be, and oftentimes more efficient or faster than laparoscopic procedures. So the probably the most important thing, though, as a patient is it's not about how fast things can get done or what's efficient or not efficient necessarily.
Right.
But rather what can how can this surgery be done as safe as possible with the best outcome possible?
Yeah, that's it. It's the outcome for the patient.
Right.
And I don't think a lot, if I'm laying there having this happen, I don't care how we get there.
That's right.
In a lot of instances, just
Right.
get me there, right?
It has to be safe and it has to be excellent outcomes. And that non-inferiority, there's no question. There's no worse outcomes necessarily with the robotic system or vice versa. It's just about doing what you know how to do best with a well-selected patient and having great outcomes. And that's the most important thing.
Do you ever think we'll get to a day where you just sit in front of a computer and you program the entire operation in and then the robot just goes in and does it?
Probably,
and
yeah.
You grab a cup of coffee.
You think about technology and technological time, or the time scale for technology. You think about when, when the turning points happen. I mean, you start with these, you remember VCRs or CD players or Walkman or AM, FM radios.
Yes.
And even the first cell phones, how cumbersome, how big, how, inefficient they were. And just within, 10 years, where we are today versus 10 years ago with technology, it's fascinating. It's mind-blowing. So that's why it's really exciting to see the things that are the robotic system and the fact that other companies are trying to develop their own systems. Ultimately, this is better for patients to have more options available to them.
Right.
And it's only a matter of time when I'm sure one day we'll be able to program everything and you'll deploy some nanites into someone's body and they'll fix the problem.
That's going to be exciting.
Yeah, that'll be great. I hope that happens as soon as possible. Yeah.
Well, before I let you go, Doctor, I wanted to, I believe, so far, I think you're the first doctor that we've had on this podcast that plays an instrument.
That's right.
Proficiently, right?
I'll take it.
Now, I had never heard of this instrument. And what is it called?
It's called the tabla.
Okay.
Tabla.
All right.
It's a North Indian percussion instrument, and it's a two-piece drum set. There's a smaller treble drum, and there's a larger bass drum. They rest on the floor where you also sit on these circular rings. They look like donut pillows.
Oh, now, okay. The rings are what kind of are popping this into my mind that I think I've seen these.
Yeah. And it's a very, the tabla is a very rich instrument in that there's a very thorough history of repertoire when it comes to tabla or tabla music. There are compositions that are set and are passed down from teacher to pupil and so on and so forth generationally that are almost, they're coveted, they're almost secretive. You don't want to let people find out what the compositions are. So it's an oral tradition that's passed on from generation to generation. And the way you learn to play the instrument is you truly submit to your teacher, who is your guru, and they essentially teach you all that they know, and they nurture you as long as you're willing to accept the knowledge.
Right.
And,
well, who taught you?
So my guru, Shashanka Bakshi, was my first tabla teacher, and I learned from him for 15, 20 years. And
wow.
At that point, I also learned from Arup Chattopadhyay and some other teachers that essentially were kind of like finishing school type touches to my playing. And, I consider myself a lifelong student.
That sounds as extensive as going to medical school to learn all of this. It almost seems...
Yeah. A little bit less pressure.
Yeah, sure. Yeah. Exactly.
Well, my mom gave me quite a bit of pressure to practice. But
now, you also, I found out you have a CD?
Yes,
too?
I have a couple CDs.
How can they find? Are you like on Spotify or anything?
Yeah, it's interesting. I don't even know if I'm on Spotify. I should check. There's so many
you
things
should.
Happening.
Right.
I have CDs. I think they might be available on Amazon, but I haven't really looked into it in a while.
They just search for your name?
Yeah, they can search for my name and find them. I took kind of a hiatus from the performing arts life after I got into medical school. So
sure.
I would still do gigs and concerts when I could, but it became much more difficult after medical school. But during vacations and even recently, for example, for Monument Health, the talent show, I try to still play, and I try to be in practice and meet people. I just like to meet artists and from different backgrounds. I think it's a great form of education.
Well, I'll have to introduce you to a lot of people around here then, because we have a ton of them.
That's
and
great.
I just told one guy out there he should incorporate what you do right now. It could be fantastic. Dr. Pial Hope, a general surgeon. You specialize in metabolic and bariatric surgery. Glad you're here at Monument Health. Thank you for coming in and talking. And get on Amazon and find his CDs too. All right, because I'm going to go search now because I want to hear it.
Yeah, thank you so much.
You bet. Thanks for coming in and talk, Doctor.
Of course, my pleasure. Thanks for having me.